Good afternoon, and welcome to our Parent Guardian Talk Series, Curative Treatments for Sickle Cell Disease. I am Allison Circo, the Regional Director of Community Outreach with Hackensack Meridian's Children's Health, and I will be your moderator. We are very grateful to have Dr. Christine Camacho Baidoom with us today. The information presented and discussed is educational in nature and is not intended to be taken as a specific recommendation for any children. We hope it'll support and complement the already amazing work you provide as parents and guardians while staying under the current guidelines from your primary healthcare physician. So a little bit about our speaker. After completion of her pediatric residency at the Children's Hospital at Montefiore in Bronx, New York, Dr. Christine Camacho Baidoom began her pediatric hematology oncology fellowship in a combined program through Memorial Sloan Kettering Cancer Center and New York Presbyterian Weill Cornell Medicine in New York. She then completed an additional fellowship in pediatric cellular therapy and hematopoietic stem cell transplant at MSK. Following fellowship, she worked as an attending at MSK before joining the pediatric blood and marrow transplantation and cellular therapy team at the Joseph M. Sanzari Children's Hospital at Hackensack University Medical Center in July of 2022. Her clinical interests center around cellular therapy and bone marrow transplant for children with malignant and non-malignant diseases, with a special focus on curative treatment options for pediatric patients with sickle cell disease. And at this time, I'm going to turn it over to Dr. Camacho Baidoom.
Great. Thank you, Allison, for that introduction. Hello, everyone. I'm excited to be here today to talk about sickle cell disease entering the new era of cure. What we hope to accomplish during this talk is just to do a brief overview of sickle cell disease. What is it? How do you get sickle cell disease? How many people are affected? And what are the associated symptoms and complications? Then we want to discuss a little bit about the review of advancements in diagnosis and managing sickle cell disease, and focusing then on curative treatment options, including bone marrow transplant and gene therapy. How do they work? Who qualifies? What are the risks and benefits? And if interested, what you should do. So starting from the beginning, what is sickle cell disease? Sickle cell disease is an inherited blood disorder that affects the red blood cells. When a person has two copies of the sickle cell gene, their red blood cells are not normally shaped. The image on the right shows on the top a normal red blood cells that's shaped like a donut, and it's easy to pass through different vessels. It's very flexible. However, as I mentioned, when patients have these two copies of the sickle cell genes, their cells are abnormal. And this is shown in the lower part of the picture that shows the red blood cells become sickle or crescent shaped. And when they're like that, they are not very flexible and therefore cannot pass easily through different vessels of the body. Since they are abnormally shaped, these blood cells are easy to break apart or hemolyze. They can clump together and stick to the blood vessels. And as we mentioned, because they get stuck in different vessels, they decrease the blood flow, leading to different parts of the bodies that include organs, tissues, or bones. How do you get sickle cell disease? So an inherited blood disorder means that you get two copies of the sickle cell gene, one that comes from your mom and one that comes from your dad. And there's a mutation or a change that occurs to the hemoglobin gene that causes it then to make a sickle hemoglobin or hemoglobin S. The picture on the left shows a family tree. The blue portion of the person is to signify their copy of the sickle cell gene. So you can see the father and mother each have one copy of the normal hemoglobin gene and one copy of the sickle cell gene. And if they have a 25% chance of passing that on to a child that will get each a copy of the sickle cell gene from each parent, and thus will be affected with the sickle cell disease. As you can see, there's a 25% chance that they have a child that is not affected at all, that got a normal hemoglobin gene from each parent, and then a 50% chance that their children may have at least one copy of it or be a carrier of the sickle cell gene. So how many people are affected by sickle cell disease? Worldwide, it's estimated that there are approximately 7.7 million people affected. In the United States, it's estimated that it's about 100,000 patients. However, we're still learning more about that, and there's some concern that maybe this is underreported, and there's a lot of efforts to try to get better data right now. It's estimated that about 1 in every 365 African American births are affected by sickle cell disease, and 1 in every 16,300 Hispanic births. Due to the abnormally shaped red blood cells that decrease blood flow to different parts of the bodies, there's multiple symptoms that can result from sickle cell disease. One of the most common is anemia. Anemia meaning lower level of the red blood cells, and that can be associated with things like people being tired or dizzy, maybe having difficulty breathing or being pale. They can have recurrent pain crises, which presents as bone pain because of that blood flow being restricted to those areas. And this is a big reason why we see a lot of patients admitted to the hospital needing more frequent pain medications or IV pain meds to control some of these symptoms. There can be organ damage to many different organs throughout the body, but some of the big ones are the hearts, the kidneys, the brain, the eyes. With the lungs, we can have symptoms such as acute chest syndrome or when patients have a pneumonia to the area. With the spleen, you can have splenic sequestration, where you have pain, your spleen becomes enlarged, and you become anemic. Your hemoglobin begins to fall. Because of these effects on the spleen, patients with sickle cell are at increased risk for infections. We know that they're at risk for strokes because of these various complications, as well as blood clots. So really, and I think this picture on the right-hand side does a good job of showing how expansive the symptoms of sickle cell can be and really affect every different part of the body. So there's been a lot of advancements in the diagnosis and treatment of sickle cell. The first case of sickle cell was identified in 1910. It took then about a little over 40 years for them to discover that it was a genetic mutation or that change to the gene that causes sickle cell disease. Once they discovered that, about 20 years later, we came up with a way to identify patients early with sickle cell disease, and that became as part of the newborn screening. New York was one of the first states to start newborn screening, all newborns for sickle cell disease in order to identify patients early. Then in the 80s, there was much progress made in managing particularly children with sickle cell, and we started to implement the use of penicillin early, as well as certain vaccines to try to prevent infections in patients who had sickle cell disease. And by 2006, it was universal throughout the United States and its different territories that all newborns would be screened for sickle cell disease. With these advancements in diagnosis, there also became some advances in treatment. In 1998 was the first FDA-approved medication for sickle cell disease, hydroxyurea, which was initially approved for adults with a certain number of pain crises, and it was later, a few years later, approved for children. However, from that time onward, it was almost 20 plus years to the next medication was approved for sickle cell. And since then, there's only been a total of 4 medications approved for helping with the symptoms of sickle cell for either adults or children. It's important to note that in this past year, the most recent medication was taken off the market. So now there's only 3 FDA-approved treatments for sickle cell disease. Despite this, though, what's quite surprising is that recent studies estimate that still only about 25% of adults or less than 50% of children are treated with these medications, despite them being around for almost 30 years. And again, these medications don't get rid of the disease. They may only help reduce some of the symptoms or frequency of things such as pain crises. But, is there something more that we can do to help treat this? So why is it important to discuss curative therapy for sickle cell disease? As we've shown, sickle cell disease is a chronic, lifelong disease that again, we identify in patients as they're newborns, and it's going to require lifelong medication management and screening, follow up with your medical professionals, to make sure that you're getting the best care. And what's important, again, we've talked about many of the symptoms and organ damage that can occur, but even if a patient is not having these outward symptoms of sickle cell disease, for example, being admitted to the hospital with frequent pain crises, they may still be experiencing some of these silent effects of sickle cell disease to various organs because of the effects of the abnormal shaped cells blocking some of the blood flow to these areas. What's also important to note is that despite the advances in treatment that we talked about, there hasn't been much change in early adult mortality since the beginning. So what this graph shows, the dotted line graph shows from 1979, and it shows the percentage or mortality in patients with sickle cell disease based on age. What we see that in 1979, there was this early bump here that patients would die at an early age with sickle cell. And this was before we were able to identify patients early with newborn screening or implement some of those treatments like penicillin or vaccines. Once those managements were implemented and newborn screening became more universal, we see that by 2006, we had decreased that mortality risk in early childhood, which was fantastic. But we can see as time went on in adults here, there was still this high mortality risk in patients after the age of 40 or so. And we still see that despite all these advancements, the expected lifespan of a patient with sickle cell disease in the United States is still around roughly 50 years, and is substantially lower than other patients in the United States without this kind of chronic disease. So what can we do to help change this? Well, in 2024, there are now 2 therapies that can cure children and adults with sickle cell disease. Those 2 curative therapies are bone marrow transplant and gene therapy that we will discuss briefly. So what is bone marrow transplant? So in its very basic form, bone marrow transplant represents the process of infusing stem cells. Now, stem cells are the mother cells that are in the middle parts of your bone in your bone marrow, and they are the cells that turn into the different parts of your blood cells. They turn into your white blood cells that fight infections, your red blood cells that carry your hemoglobin, and your platelets which help with bleeding and clotting. So we infuse stem cells from a healthy donor into a patient to replace their bone marrow that is not currently working properly. And that could occur in a case like a patient with sickle cell disease. In order for a patient to undergo a bone marrow transplant, they must be prepared in order to receive those stem cells from a donor. And the way that we prepare a patient for a bone marrow transplant is by giving them chemotherapy. And we give them chemotherapy for 2 different reasons. One, we want to lower their immune system in order for them to receive those donor stem cells. And 2, we want to make room in their bone marrow for the new stem cells to occur. Then we will infuse the donor stem cells into the patient, which then travels to the bloodstream, goes to the bone marrow, and produces all the new cells of the blood, as we talked about, including the red blood cells. And with this new bone marrow, the patient will no longer have sickle cell disease. It is important to note that bone marrow transplant for sickle cell disease has been practiced in the United States since 1984. That was the first time a transplant was successfully done for this. And since then, we have made much progress in improving the ways that we perform bone marrow transplant, as well as expanding our donor pool. So when we're talking about a bone marrow transplant, we mentioned that we have to get stem cells from the donor. So how do we find a donor? So you find a donor by doing something called HLA matching. So when we talk about HLA matching, we're talking about certain markers on our cells. Every person has a certain number of markers on their cells that are called HLA. And those come, all of us have 1 copy from our mom and 1 copy from our dad. And when we're looking for a donor, we're looking to see if our patient has the same markers on their cell surface as a potential donor. And if that occurs, then we say that we found a match. If they don't have the same markers, then they're not a match. When we are looking for these donors, we initially start with looking for related donors. So what that means is that we will HLA type the different members of their families, particularly their siblings, and look to see if the siblings have, again, the same type of markers on their cells as the patient. And the picture on the left here shows, as depicted by the squares and circles, that our patient in the yellow shirt has the same markers as the sister in the light blue shirt, and they're considered a match. However, there's a chance, as we had shown in the previous pictures, that there's a 25% chance the siblings may not be a match at all. They got different copies of the markers from their mom and dad. And there's a 50% chance that they may just be a half match with one of their siblings. If we cannot find a match amongst the family, then we can do what we call an unrelated donor search, meaning we look at the big donor pools that collect HLA typing from people all over the country and the world. And we look to see if our patient shares the same markers on their cells as another person, again, an adult from anywhere in the world. And if they have those same markers, then we have a match for an unrelated donor. However, finding a donor is not always as easy as it may sound. For patients with sickle cell disease, it is estimated that about less than 25% of patients will have a matched sibling donor, which means most will have to look for potentially an unrelated donor. We know when we look for an unrelated donor in these large donor pools, the percentage of finding a matched donor is affected by race and ethnicity. It's estimated that a white or Caucasian patient will have about a 77% chance of finding an unrelated donor in the large donor pools. However, that percentage decreases the more ethnically and racially diverse our patients are. And when we get down to patients who are African American, there's about a 23% chance that we will find a fully matched unrelated donor. So this is where, due to the difficulties finding matched donors, why there started to be thoughts of, are there different ways that we can cure sickle cell disease without needing a donor? And that's where gene therapy comes into play. So what is gene therapy? Gene therapy, in its very basic terms, is the introduction, removal, or change in a part of a gene in the cells of a patient to treat a rare or inherited disease. And this can be accomplished by gene editing or gene addition. And what that means is that by changing or adding, in the case of sickle cell, to the sickle cell gene therapy, then it can affect the production of the hemoglobin and produce more non-sickle red blood cells, which then improves hemoglobin levels and improves the symptoms associated with sickle cell disease. In December of 2023, there was FDA approval of 2 different types of gene therapy products, Lyfgenia and Casgevy, by 2 different companies. So that was quite exciting. So what is the gene therapy process? So in order for a patient to undergo gene therapy, we must first obtain their stem cells. So gene therapy uses a patient's own stem cells, so you don't have to find a matched donor like you do in bone marrow transplant. And this process is accomplished. The patient has a large, essentially IV or a temporary line placed. They are hooked up to a machine, an apheresis machine, which helps remove the stem cells from their blood and returns all the other components of their blood back to them. These stem cells then are taken to a lab where the gene editing or gene addition process occurs to change, to help to change the sickle cell gene or add that new gene. And then, and this process can take, a few months. Then the cells can be infused back to the patient. However, before doing so, we do have to treat the patient with chemotherapy, as we did with bone marrow transplant, in order to lower the patient's immune system and to make room in their bone marrow for these new cells. Then those new stem cells are infused into the patient, they travel to the bone marrow, and they start remaking all of the new blood cells. By doing so, helps, again, cure the patient of their sickle cell disease. So, one big question that people have then is, can any person who has sickle cell disease qualify for curative therapy? And as of right now, there are certain criteria that patients need to meet in order to receive different types of curative therapy. So in the cases for bone marrow transplant, if a patient has a matched sibling, a donor, then the qualifications for bone marrow transplant are less strict. The patient needs to be at least 2 years of age, and their sibling donor typically needs to at least be 1 year of age. These patients can have a range of symptoms. When we first started bone marrow transplant with matched sibling donors, patients used to have much more severe sickle cell disease. However, once we realized, how safe the process was and, how successful it was, we now realize that we can take patients with less severe disease and sometimes even no symptoms if they have a matched sibling donor. So the range of symptoms can be quite large. And particularly, we found with matched sibling donor, the patients do much better the younger they are. So there really is a push, if patients are interested and have a matched sibling donor, to really try to do that transplant earlier. For patients who don't have a related donor, such as a sibling, the qualifications for unrelated donor transplant require the patients to have a little bit more severe symptoms. And those can be, more frequent hospitalizations for pain crises within a year, or they have frequent recurrent acute chest syndromes or things like stroke. And if they have those symptoms, they may qualify for an unrelated donor bone marrow transplant. For gene therapy, the qualifications right now, so for the 2 FDA-approved products, those were currently approved for patients greater than 12 years of age and actually extends all the way to 50 years old. Those patients, though, must show that they do not have a matched sibling donor. The reason being that, again, we've shown that matched sibling donors are very effective for bone marrow transplant and very successful. So it's, again, right now approved for patients who do not have that sibling donor. However, they do have to show that they have a certain level of symptoms of sickle cell. And currently, the criteria requires you to have 4 vaso-occlusive events. And those could be things such as pain crises requiring hospitalization or ER visits, acute chest syndromes, or splenic sequestrations that occurred within the previous 2 years. At the moment, it is likely that patients cannot have a history of stroke. However, those indications may be slightly changing, in the future as we learn more about some of the previous patients who have undergone these treatments. For patients who are less than 12 who may be interested in gene therapy, the way at the moment is that you would need to qualify for a research study looking at gene therapy for sickle cell patients. And often the qualifying criteria is very similar to those used in the commercially approved products. So including those 4 vaso-occlusive events in the previous 2 years. So what are the different complications we need to consider when talking about curative therapy? So both sets of curative therapy involve chemotherapy. So there are the side effects associated with chemotherapy of short and long-term side effects. There's something called graft rejection or graft failure that we'll talk about in a moment, that primarily is a consideration with bone marrow transplant. We have to consider something called graft versus host disease, and that's particularly a complication associated with bone marrow transplant with the uses of either related or unrelated donors. Both types of curative therapy have risk of infections because we've lowered the patient's immune systems by giving them chemotherapy. And they can be at risk for different types of infections like viral or bacterial or fungal infections. There can be different effects on the organs, such as the liver, kidney, or lung because of the use of chemotherapy and other types of medications during these processes. There's a risk of infertility because of the use of chemotherapy, and infertility meaning the inability to have a baby later in life. And with any big process, such as transplant or gene therapy, there's always a potential risk of death. although that risk is usually quite low, particularly in the younger patient population. But again, it's never a risk of zero. So we talked about graft rejection or failure. So what is that? So what that means, and this is something that primarily occurs with bone marrow transplant, and that means that we prepare the patient, we give them the chemotherapy, and we infuse the stem cells. However, something in the patient recognizes that those cells are not theirs, even if they're completely matched, and the patient's body starts to reject them. And if that occurs, that means that the transplant does not work. The patient's own stem cells come back, so they're not cured of sickle cell disease. The risk of graft rejection and failure has improved over the years, but again, it's not zero. It's quite low for when used with matched sibling donors. At some estimate that it's about 5% or so. However, that risk does increase with the use of unrelated donors, and as well as mismatched unrelated donors. Graft versus host disease is another complication seen with bone marrow transplant that we hear a lot about. And what that means is that after the infusion of the donor stem cells, the stem cells take over, they start producing the new red blood cells, white blood cells, and platelets. However, something of the donor cells recognize that they're not in their original body, that they're in a new body. And when that happens, the donor cells can start to attack different parts of the patient's body, and that can result in certain symptoms. They can have rashes, it can affect their GI system, which means they can have nausea or vomiting or diarrhea, and sometimes it can affect their liver and cause abnormal liver tests. Because we know that every transplant has a risk of graft versus host disease, we do give patients medications to try to prevent this. And we have been quite successful, particularly with matched sibling donors, in decreasing that risk. However, that risk, again, is never zero, and the risk can go up with our use of either unrelated donors or donors that are not fully matched. So when considering the different types of curative therapy, it's important to try to compare and contrast them. So this, and that's what this image here is showing. So the pros of bone marrow transplant: it's been an established treatment for over 40 years in the United States. So there's been a lot of research and long-term follow-up with these patients, and we've made a lot of progress in ways to try to prevent some of these complications and decrease things like graft failure or graft versus host disease. However, the cons is you need a well-matched donor is how it works best. And we talked about how that ability to find a matched donor can be affected by things like race and ethnicity. And because you have the use of a donor, you have a higher risk of certain related complications like graft versus host disease. Gene therapy, the pros of gene therapy is that you don't need to have a well-matched donor, which potentially makes this treatment available to more patients, because as we've shown, it's the percentage to find a well-matched donor can be difficult. And because it's using the patient's own cells, there's not a risk for donor-related complications with things like graft versus host disease or with rejection. However, one of the cons is it's a newer treatment. Although it's been ongoing since about 2015, there's only about 8 or 9 years of follow-up so far. So we just don't 100% know yet what the long-term data will look like. So that's one thing to keep in mind. However, how are these two therapies similar? They both involve the administration of chemotherapy and thus are associated with different short and long-term risks associated with that. There's risk of infections after the treatments because of the lowered immune system. However, the one good similarity, obviously, is that they both are potential options to cure sickle cell disease. So what to do if you want to learn more about different curative treatment options? Definitely start talking to your primary hematologists and ask them if these are potential options for you. If you haven't undergone HLA typing yet, you can definitely request to have that done to check to see if there's any of the siblings are potential matches for the patients. You can always schedule a consultation at a bone marrow transplant or a gene therapy center to learn more information. you can at least assess if you qualify for any of the therapies and discuss to see if there's a better option for you. The National Donor Marrow Program also has a specific sickle cell Connect program that provides information for patients that are potentially interested in things like bone marrow transplant. So that's also a good resource for patients to turn to. So in conclusion, I hope we showed that there's been much progress made in matched sibling and alternative donor bone marrow transplant for patients with sickle cell disease over the past 40 years. Gene therapy has been shown to be successful at curing sickle cell disease since about 2015 without the need of a donor. And most importantly, we hope that we showed that information is key. Definitely get HLA typed, talk to someone to find out your options, just so you can make the best decision for yourself and your child to see if any of these are potential options. And thank you so much. And I will can review some of the questions that had come in.
Thank you so much, Doctor. So we will get to a few questions right now that have been submitted. The first question is, are the treatments mostly for younger sickle cell disease patients? I typically only see or hear of young children receiving the new treatments.
Great, no, great question. So no, the bone marrow transplant and gene therapy can be offered to both pediatric patients and adult patients. However, as we discussed, we have found that the younger you are, the better the patients do. And part of that is one, as we talked about, that sickle cell is a chronic disease that can cause this kind of silent damage to your organs and different systems. So the thought is, if you undergo these processes earlier, you may be healthier and not have that level of damage yet to different organs. So that's why there's a focus on trying to get patients, if you're interested in that treatment, cured earlier. But definitely if there's older patients out there or adult patients, definitely, again, speak with your team and speak with a transplant center or a gene therapy center, because they may be able to speak better to what type of options are available.
Thank you. The next question is, 23 years old, a warrior, can I get cured?
Yes. So as we discuss, in terms of age requirements, things like bone marrow transplant is available to patients of any age, greater than at least 2 years of age. Gene therapy is currently available for patients greater than 12 years of age to about 50 years old is what it's FDA approved for at the moment. However, you do need to be seen, speak with your hematologist or seen at a bone marrow transplant or gene therapy center so they can review your history and see, again, if you meet those certain qualifications for the different types of curative therapy. But based on age alone, yes, a person of 23 would be potentially eligible for these treatments.
Okay, the next question is, are more complex sickle cell disease patients ineligible for treatments?
Great question. So no, not necessarily. As we talked about with bone marrow transplant, for matched sibling donors, you can have any range of symptoms. So ones who are, again, have barely any symptoms, to those who have very severe or complicated symptoms, things like strokes, as well as pain crises or acute chest. If you have more of those severe symptoms and you don't have a matched sibling donor, then typically you would be eligible for an unrelated donor transplant, and that's someone who's either a close match or complete match to you. For gene therapy, in terms of more complex cases, it depends what your complex complications are. But typically, if you have those frequent pain crises or acute chest, you would be eligible. If you have more neurological symptoms, then you may just need to speak to one of those centers just to confirm what exactly the symptoms are, what your imaging findings are, just to see if that's something that's potentially available to you.
Thank you. The next question is, how do you get the opportunity for these treatments if your hemat team doesn't push for it? What actions can a parent or caregiver take?
Yeah, so, and we definitely hear this from patients and families. You can definitely, reach out yourself to your local centers that have these treatments and request to meet with someone. Our team often will meet with patients for these initial consultations just to give information. Again, sometimes it's an early consultation. The patients may not be eligible. We provide them with the information, and then they can, once they're at least of age or maybe have a certain symptoms, they reach back out to us. Again, there are different organizations like the NMDP, which has some information on its websites to help, again, parents that may be interested in this but have not been provided this information from their teams yet. So you can look there and they can help you find your local centers. As well as when it comes to gene therapy, the two commercially approved products, those companies also have a lot of patient information available on their websites that can help you, again, find a center that's offering it near you, or at least find out more information to see if you're potentially eligible for that treatment.
Thank you. The next question is, I am South African from Cape Town. Would we also have these options available to us? I would love to get help for my daughter who has had numerous crises from sickle cell.
Yeah, so unfortunately, I'm not too familiar with what some of the international centers are doing. We at the moment have these available for patients that are, living in the United States. So again, you may have to speak to a local center to see what's available for that. But again, I'm unfortunately just not as familiar with those options.
All right, thank you. And the last question is, can we find out if and when a study will be written for gene editing therapy to get it approved for someone with sickle cell?
Yes. So again, there are multiple studies ongoing with either gene editing or gene addition at the moment. And those are for some companies, depending on which if it's a newer technology, is ongoing in different age groups. There's some ongoing for adults, some currently ongoing for more adolescents. And then for the companies that already have the commercially approved products, there are current research studies ongoing looking at evaluating those current treatments in the younger patient populations. So looking at right now, they're looking at patients 5 to 12. And once that study is complete, then they will look at even that younger pediatric population. So really, if someone's interested, it's really, again, reaching out to your local centers and seeing what studies are open for the different age groups.
Great. Thank you so much, Dr. Camacho Baidoum. This was so helpful and informative. And I want to thank everyone that joined us for taking the time to listen. Please visit our website at hackensackmeridian.org/events to learn about other Parent Guardian Talk series and other upcoming programs. Again, thank you, Doctor, for this very informative talk. And thank you for those listening in. We hope you enjoy the rest of your day. Thank you.
Great. Thank you.